Hello, and thank you for joining us for the first ever episode of HIV Reimagined from the HIV team at UNICEF HQ. I'm your host, Dr. Shaffiq Essajee. I'm a pediatrician and I've been working in public health for over 20 years and specifically in the HIV epidemic. And I'm very delighted to bring you this brand new podcast full of conversations for change. How can we reimagine a future for HIV and health programs? In each episode, I'll be talking to people around the globe to share their perspectives of doing things differently across a whole range of health services. We'll be speaking to change makers on the front line of service delivery, as well as hearing directly from service users as we take a look at what changes are emerging in healthcare, especially since the impact of the COVID-19 pandemic. Plus, I'll be talking to studio guests to dig into what all these new ideas, innovations, and ways of working could mean for the future of HIV services. We'll be talking about some of the hottest topics in healthcare, from mental health to youth services to what's next for diagnostics. And today, for our very first episode, we're tackling a subject that is tightly linked not just with HIV, but to almost every aspect of health and well-being. Today, we'll be talking about mental health. COVID-19 had a complex impact on mental health that is still being understood. But we do know that the pandemic challenged mental health services like never before, with demand and need rising due to factors such as isolation, fear and loss of loved ones, combined with access to services decreasing. And we're really going to get a global look at mental health as we meet people to talk about mental health services, experiences, and perspectives from Asia, from the Middle East and North Africa, and from sub-Saharan Africa. In today's episode, we'll be finding out about a really unique community-led idea that connects those at risk to the support they need, but in a place you might not expect. Plus, we're talking to a youth group about the benefits of integrating physical health services, mental health services, peer support, and having fun. And we'll also be sharing a very honest conversation with a service user from a marginalized group in the Middle East and North Africa region who has finally found an innovative service that has revolutionized their mental health care.
Having the grandmothers on board, this is something that has been adopted from the culture that already exists.
That huge part that was reflecting on my mental health, I had to hide it.
We just took everything. It's a one-stop shop. We took everything that has to do with cleaning, that has to do with them interacting in a one consultation room.
And here in the studio, I'm joined by Raj Mariwala, the director of Mariwala Health Initiative, an advocacy, capacity building, and grant-making organization focusing on accessible mental health, especially for marginalized communities. Raj, your bio also says you're a practicing canine and feline behavioralist. Please tell us about both of these.
Thanks so much, Shaffiq. It's so good to be here and to be asked about both of these. So while I do work at Mariwala Health Initiative as the director, and I approach this work from the lens of lived experience as someone who lives with a mental health condition, a learning disability. And so that's one part of my life. My first job, however, is working with dogs, cats, and their humans on the behaviors that are causing problems. So I do work with, I guess, human and companion animal mental health.
And the two are not entirely unrelated, are they, Raj?
Not at all.
During the pandemic, we saw a huge upswing, of course, in mental illness, but also in the numbers of individuals that got themselves new pets.
Absolutely.
We also have Peter Yaro joining us today. Peter is social development worker and public mental health specialist, and he is the executive director of BasicNeeds-Ghana, a mental health and development advocacy organization. Peter has over 20 years of experience in the mental health and development space. Welcome to the show.
Thank you, Shaffiq, and great to be here and to have my co-discussant Raj, who we had met previous years ago, and great to be connected. And once again, thank you for inviting me to be part of this discussion.
Yes, indeed. You are both mental health warriors in your own respective communities, and it's fantastic to be able to host you today and to hear a little bit more about the work that you've been doing. Over the course of today's episode, we'd really like to talk to you both, not just about mental health, but also where you think there are both similarities and differences in the contexts in which you work. We'd love to know where you see common ground in terms of community and social norms, how mental health is viewed, and what this all means for people in need of mental health services. And we also want to see if there are large contrasts between your two different countries and the settings in which you work. So let's get started, and we're not going to make things easier. We're going to start our conversation today with a really big question. Raj, you're based in India, and Peter, you're in Ghana. How would you both describe mental health understanding and mental health care in your national context?
Okay, I mean, that is a big question. So 150 million people in India are in need of active interventions for their mental health, right? Now, 80% of those living with mental health issues have remained without support despite being unwell for over 12 months. But I think the key kind of statistic, if I am to look at this, is that less than 30 million of these 150 million people sought mental health care. Now, that happens, I think, for a variety of reasons. One is, of course, access. Where is this care? Do we know where to find it? Is it something that's going to be comfortable for us to approach? And that relates, I think, very closely to the type of structure and systems that have been set up in India. And the factors that kind of affect this are awareness, the way mental health is provided in India, which, if I'm to just give you an example, if I'm someone who's living in a smaller town or a village, it's very likely that I'll have to travel away from my home using public transport, maybe even speaking in a different dialect to figure out where to get a certain type of mental health care, right? So that in itself is quite daunting. Then comes the whole idea of stigma. And here I'm going to say that the stigma not just related to mental health and accessing mental health, but what happens once you are seen as needing mental health care. What happens to your employment opportunities? What happens to education opportunities? What happens to your social status? So I think it's a multifaceted problem. It's a rights-based issue. And in a place like India, which I'm not sure whether it would share similarities with Ghana, but poor mental health is very deeply related to poverty, compromised education, gender inequality, physical ill health, violence, and other such global challenges. So really, it's a development issue.
Yeah, how mental health is perceived in Ghana is a bit mixed, and I entirely agree with what Raj just said. But when you were mentioning figures, about 150 people needing mental health care, Ghana is just a little over 31, nearly 32 million people. But we have very similar situations. Mental health is generally perceived negatively in Ghana. Negatively from years of socialization that have made the average person see a mental health condition and a person living with a mental health condition as reaping or paying the effects of past sins or evil things that either the person individually or his ancestry line of people lineage might have caused, or even current bad deeds, especially if you are a young person and it is felt that you have been associated with issues of drugs, of truancy, or some juvenile misdemeanors and behaviors that are now landing you into this ultimate punishment that you are getting. And so, averagely, people see someone having a mental health condition as, well, this has been brought upon you for one reason or the other. It's not seen as a medical or a health condition as such, but as something spiritual, supernatural, and because of that, response to it would start from the supernatural realm, trying to counter whatever demonic attack that you have suffered. And let me also quickly add, people may also see you as just being an unfortunate victim. You just happened to be in the crossfire, and so you were hit by this that was probably meant for someone else. And in such a situation, you may draw some sympathy and understanding, but in the general overall view or perception, this is something that is a calamity either brought upon yourself or you are just being an unfortunate victim. And so that also informs the response that would associate with the condition, starting with going for spiritual or supernatural remedies, even before they think about medical or health interventions. And as a result, politically, there is low priority placed on mental health. And that translates to how much resource allocation, infrastructure, and all that to address mental health issues are looked at and provided.
That's extraordinary, Peter. So if you don't think of it as a health issue, then the availability of health services doesn't even come up as a point of advocacy in some sense. Raj, when Peter is talking about this distinction between the way in which physical health and mental health are distinguished in people's perceptions, does that resonate with your experience of working in India?
Well, I think, when Peter started to talk and spoke about superstition and faith healers, that's something that happens very often here in India. And people do go to faith healers when it comes to feeling stressed out, maybe feeling disturbed. Now, a faith healer is definitely far more accessible than your average mental health professional. So it's understandable why there is such a push. But I think when Peter was talking, part of the stigma really, I'm reminded of what it means when we say mental illness. And I think we do probably have a shared history because the idea of mental health treatment came to India when the British got in asylums. And that was put in under the charge of police, law and order. So it connects back to what Peter was saying then about, criminality. And so that tends to get associated with it. It tends to get scary. So I do see some resonance there with what Peter's saying, but overall, in terms of articulation of mental illness, it's really interesting because people, when they do want to talk about things, they may be talking about stress or distress in a more psychosomatic manner. And that's just in the way that we express, because a lot of people may not speak in English, and so people may express things about their mental health in ways that a traditional mental health system, which is largely Western-based, doesn't understand, this mind-body separation. So I think there's resonance and maybe difference as well.
Peter, what does the lack of attention and political will actually mean for the availability of services in your country?
It's that far to the extent that even simple drawings of medical facilities, hospitals, and health posts will forget to include psychiatric or provide wings for psychiatric services until being reminded. Like I had to raise concerns that a government program to provide several hospitals, starting from 88 to 110 of them. The initial drawings did not include having psychiatric wing. And this is purely a clear demonstration of how the policy authorities trivialize mental health to the extent that they don't think that including facility, psychiatric wing, or a mental health unit in a modern hospital means much. So that's one clear example.
Even at the design level, it's not something that's even considered.
No. And going bigger is even the financing of mental health care. As rightly mentioned, structured medical treatment for people who had mental health conditions was merely in the realm of the herbalists and the faith-based healers until our colonialists brought hospitals and the asylums came into being. So most policy authorities in Ghana still think about mental health just within the realms of what they call the psychiatric hospitals, the asylums. And so when they say, oh, we have given so much to mental health, it is that they're giving an allocation for feeding of patients who are admitted at the 3 psychiatric facilities. Investment into community-based mental health care is still a far cry of what it should be. And when it comes to human resources specialists, training psychiatrists and the rest is still disappointingly very low. Political authorities, as I always describe it, see mental health as an afterthought. And that is how that is affecting the rate at which we could have invested in mental health, we could have transformed mental health and made it part and parcel of the healthcare system and ensuring that policy-wise it is very much part of it. Just because of, as Raj mentioned, it's a human rights issue, it's a development challenge that we need to take on board. If we are talking about inclusion, we are talking about social protection, then they need to invest in mental health.
I just want to hop in and say I cannot agree with you more, Peter. And of course, too, there is absolutely a shared experience here. What Peter was talking about in terms of financially and otherwise other types of monies from governments going to the big institutions. So like Peter said in Ghana, in India as well, the money and the focus is on 2 very big psychiatric institutions, despite us in India having a certain amount of political measures put in. So, for example, Indian law says there must be a psychiatrist in every district hospital dispensing 3 medication. That has never happened. It's still, a far cry. So there are absolute similarities, I feel, in India and Ghana in that aspect, that unfortunately it's only the very big institutions, the tertiary health, that gets any type of attention, whereas the community-based inclusive mental health approach is not, I guess, given as much in terms of resources.
And I think both of you observed that some of this is rooted in colonialism, that it was the Western concept of an asylum or an institution for caring for people with mental illness or incarcerating people with mental illness that in some ways disenfranchised community systems that existed to support people with mental illness. And when we were making this episode, we asked a lot of people across the board about projects that they would like to include in the episode where things are being done differently. One project came up again and again, and this is the Friendship Bench in Zimbabwe, a mental health service that has been entirely designed to serve the community that it's in. The Friendship Bench trains and empowers people in the community to deliver talk-based therapy on outdoor park benches, all in discreet, safe spaces like under the trees. With a focus on cognitive behavioral therapy and problem-solving therapy, they've already seen an 86% reduction in depression and suicidal ideation. Their impact has been so great that they have expanded to locations in over 6 countries, including New York, and they recently had a bench at the FIFA World Cup in Qatar. They've also branched out into youth-specific friendship benches, and we spoke to Mary Wadzanai Munetsi, the implementation manager at the Friendship Bench, to find out more.
Hi, my name is Mary Munetsi, and I am the implementation manager for Youth Friendship Bench. Unlike other mental health services, Friendship Bench services are for free for everyone. Another thing that makes it different is we have lay people who are trained to offer the service or maybe to give the talk therapy. So these lay people include grandmothers who work in the community. And for the Youth Friendship Bench, it is peers who will be giving the therapy to other peers. You realize that having the grandmothers on board, this is something that has been adopted from the culture that already exists in Zimbabwe. Because if one was feeling depressed or maybe they feel they want to share, they would approach maybe a grandmother, that is either your mother's mother or your father's mother. So, and these would sort of give advice. So this is a model that really incorporated at the cultural aspect, whereby it's not really something that is new or that is given to the community to implement, but rather it's something that already existed in the community. Friendship Bench came in to just make use of that, or maybe just to put that on the spotlight. A Friendship Bench session is just like a normal interaction, one talking to a friend. So it really isn't really formal. Of course, the grandmothers will be going through steps, but the client really doesn't know that we are on step 5 or step 4 or step 3. Rather, it's just one sharing with a friend or with a grandmother or with a buddy. The grandmothers that work on the Friendship Bench, they also have testimonials that it has had an impact on their own lives. Back then, one might also mention that they didn't know how to deal with depression when it hits them. But through the problem-solving therapy, they can also administer it in their own lives and even help their family members if they're going through depression. And also the communities, through the community awarenesses, it's getting an appreciation because it's something that people have been living with without knowing that it's a mental health condition and it's something that one really needs help on. When we talk of depression in Zimbabwe or in Shona, it's kufungisisa, which maybe translates to thinking too much or overthinking.
The Friendship Bench is a service designed entirely for the community it's in. Raj, how important do you think it is that mental health services are not delivered as a one-size-fits-all approach for communities? What are the issues rolling out what we sometimes might see as a westernized approach?
I think it's critical to examine this carefully because it never gets articulated, first of all, as a westernized approach. But when we take a look at it closely, if we see how that approach is copy-pasted, it can be quite alienating for folks who may not speak English, who may not be aware of the more biomedical terms, such as anxiety, depression, especially when there are cultural ways in which to approach distress. So I think partly it is the whole idea that there is this expert who has been schooled in a certain way, and I will have to go to this person. That in itself can be very challenging, not to mention beyond, I think, just speaking the language that the expert may speak. Different diverse communities have varied ways of communicating distress. We need a system that is accessible. Accessibility is not just about presence. It's about actually, is this person going to be able to talk to an outsider who has been schooled in a certain tradition? And while it may be okay to do so for, say, for example, a diabetes camp or an eye camp, mental health does not function in quite the same way. Also, I think because if you are talking to an expert about mental health, you may be labeled as someone who needs this kind of care or support. And then that labeling can have very real consequences and dangers. Losing a job, losing a spouse, not being able to marry, So I think there are multiple barriers to access if we look at rolling out a one-size-fits-all approach.
Well, despite the successes that the Friendship Bench is having, we also spoke to Mary about some of the challenges that they face.
Okay, so one of the biggest challenges that we have maybe come across is that some people it's not everyone that really appreciates Friendship Bench. But some people tend to be sort of skeptical about the grandmothers providing a therapy session. So people tend to think if grandmothers really know what they're doing, but you then tend to have the appreciation when one really have or maybe a session with the grandmother. Then another challenge is that has been that we don't have as many males coming to the Friendship Bench. Hence, you realize that we are having like a lot of suicide cases rising, right, when it comes to this gender, the males. So it's something that we, as Friendship Bench, we are working on, because most of our delivering agents have been women, grandmothers per se. We don't have a lot of grandfathers in our facilities. So it has been a challenge having men coming for sessions for whenever they feel depressed. So this has been one of the biggest challenges that we have had, or maybe we are encountering.
It struck me as I was listening, we have on the one hand, what I think both of you feel quite strongly is this sort of colonialized, imported structure of the asylum or the mental health institute. Some are obviously better than others. That stands out as something that doesn't necessarily sit right within the communities in which we're living and working on a day-to-day basis. But at the same time, even community models like this Friendship Bench idea rely upon westernized ideas of cognitive behavioral therapy, where a stranger looks you in the eye and asks you personal, private questions about your life. So it strikes me that there is a need to be sensitive to cultural context, even if you are adopting a community-based model.
Absolutely.
So I actually do want to jump in here. There is one key difference between initiatives like Friendship Bench and what one would understand as a more westernized approach. And that is the whole idea that it's not the expert or not a top-down approach, no matter what methodology you use to deliver care. Now, there is something extremely powerful in community members or your peers providing that care, because they already, like you, have a close connection with the social fabric of the place and of the community you belong to. They share your living circumstances maybe, and they're able to communicate about distress using context-specific and accessible language. And so in that sense, it's quite subversive, because it is quite different then from a clinic, from a professional, from an expert who still has echoes of the asylum, so as to speak. So in that sense, it is subversive and quite different. And I will give you an example. There is one district in Maharashtra, which is the state that I'm located in, that has a high incidence of farmers dying by suicide. And one of the programs running there has young people from colleges who go from door to door, building awareness, talking about the need to discuss distress. And that in itself is a mental health intervention that has helped with actually saving lives.
It made me at some point feel that we probably thought the asylum idea was bad in itself. Not at all. It's just that we are saying it can be perfected, maximizing the community health systems or community-based health approaches, which are more culturally suitable or acceptable to us than institutions. And I think over the years, especially in the 20th century, even in Europe, they've all agreed that institutionalized care is not very much the best way to go. So we are evolving, we are building upon, discarding what is not the best, embracing what can enhance. And so it doesn't matter at what point it was introduced. We just need to recognize that as we move on and get to understand better, asylums are not necessarily the answers now. We need much more enduring and sustainable community-based integrated systems that maximize social networks in responding and addressing the mental health care needs of the population.
That's really interesting. We'll be hearing from Mary again later. And if you want to hear more about how they're specifically working to support young people, head to our blog at childrenandaids.org/HIV Reimagined. Raj, Mary touched on the problems with supporting men with the Friendship Bench. How important do you think it is that mental health services are designed around the different needs for men versus women and other populations in general?
I think it's absolutely critical to take a step back and look at how our curricula and services are designed. So most services are designed to say that we will focus on X, Y, Z, but rarely do we acknowledge the sort of social norms that actually go into our mental health curricula, the curricula of side disciplines, and then, of course, trickling down to our services. And again, it's another type of default or the dominant that we don't discuss, just as we didn't or don't look at the Western as much. But whether it's decision makers and systems, all of these are reinforcing certain social norms. So, of course, services are going to be more accessible and cater to those who match societal ideas, right? The prototype of client that either curricula or services are designed for is more than likely to be cis heterosexual, able-bodied, white, and male, right? So if we are to offer mental health services that are accessible, we must be intentional about informing ourselves with and by the gender spectrum, by disability, by race, by structural oppression, and of course, looking at the cultural context. You know, the Friendship Bench, in a cultural context, it may be harder for young men to speak to grandmothers. So what are the ways in which the community itself tackles that? How is one going to look at the community as a space to bridge some of these barriers is important to discuss and engage with at the outset.
Thank you, Raj. It's time to hear from a service user to understand their perspective. And it's especially interesting because they're going to share their experience of the issues that they faced within a marginalized community. We'll be using an alias for this discussion to protect their identity. Noor is a 20-year-old lesbian queer person living in the Middle East and North Africa region. They use they, she pronouns, and while they know they're not cisgendered, they've not chosen to label their gender identity at this time. Noor benefited from the LGBTQI-friendly mental health services provided through MENA Moves. The USAID-funded MENA Moves project was implemented by FHI 360 in Tunisia, Morocco, and Algeria between September 2021 and October 22. The project intended to address the high unmet need for mental health support for HIV program providers and beneficiaries, and it did so by providing free, confidential mental health care to program implementers and vulnerable groups. These included young lesbian, gay, bisexual, transgender, queer, and intersex people, and those of other diverse sexual orientations and gender identities. MENA Moves connected those interested in mental health support to trauma-informed, non-stigmatizing psychologists via an online reservation and case management app that allowed users to easily make reservations for in-person or virtual services using a smartphone, tablet, or laptop. Please be warned that in the following conversation there is mention of suicide.
Hello, this is Noor. I'm 20 years old. I found out about MENA region through social media, Facebook to be specific. I was looking for a safe space when I can actually get free therapy because as a teenager, you cannot really afford therapy on your own, knowing that you're not financially independent. So combining that with the fact that therapy in general is not really safe for LGBTQ members in too many countries, I think it's the very perfect combination.
We asked Noor whether before MENA Moves they had ever had a counselor who they'd felt safe with.
No, never. I had to lie to my first therapist. Like, I had to hide the fact that I was, at the time, having body dysmorphia. I had to lie about the fact that I was attracted to another gender other than a male, and about my love life in general. So that huge part that was reflecting on my mental health, I had to hide it. So it was not going perfectly smoothly and for the benefit of both of me and her as a therapist. And when I tried to come out, she threatened me to tell my parents. So I was like, okay, cool. We're not doing this anymore. You know, I do recall some tragic events that my friends have been through. Like they would literally get assaulted and get threatened by life. Like their therapist would out them to their parents, their loved ones. I don't know how to say this, but for a teenager, I'm talking about underage patients, it was miserable and some of them had to end their lives. So, yeah. When I found MENA Moves, they offered me free help services, therapy to be specific. I could be myself throughout the whole therapy process. I could be open about everything that could help me to heal and to experiment more and to find out who I actually was. And was a dream because it marked a huge difference for my friends, for me personally, for even our families, because some of us, like one of my friends, had to include her therapist to help her family understand her better. And I mean, I think our region, our country, our culture needs a lot of things to be done differently, especially when it comes to mental health services. We need more and more reliable providers of mental health services, especially to LGBTQ community, women, and people with special needs. And to achieve that, we do have to provide more safe therapists, more safe specialists, more safe people to help guide those particular members, you know? I think if there were 10 of my therapists, my region would be perfectly fine. And we can rely on technology to have therapists from around the world that are perfectly safe and perfectly fine and can provide what we need and help online if they cannot really reach us out. Personally, mental health service is a need. As much as other people need oxygen and food and water to survive, we do need therapy and treatment to survive, especially for LGBTQ community, because, it's neglected in some regions and even threatened. And I would like to have more of attention for those people, including myself. And I would like to raise more and more awareness of how important it is actually to provide those services. Therapy is not done like it should be. A lot of people are being falsely diagnosed and lives are ruined that way. I don't know when this is going to end, but I hope it ends soon.
Thank you so much, Noor, for speaking out and sharing the difficulties you've faced finding the right mental health support and the difference it's made. If you want to find out more about the MENA Moves project or anything else you've heard today, please head to the episode notes or visit childrenandaids.org/HIV Reimagined. And Raj, have you seen good models for how mental health services are delivered to queer communities in India?
I would guess that while model may be a hard reach, there are services that are now not heteronormative, that don't see cisness and heterosexuality as the default, but they're few and far between, unfortunately. Because I think largely, again, services and models tend to reflect the dominant social norms. So, in fact, India is a place where our young persons are dying by suicide in very high numbers, and part of that is very much related to problems around gender sexuality, be it anywhere on the spectrum. The most promising types of services and models are coming when sexual and reproductive health and rights is closely linked with mental health support, and then providing agency, power, and autonomy to young persons is then critical when it comes to mental health support, especially if you fall outside the default.
Thank you both. I think we've had a really rich conversation and we've covered a lot of ground and got a very good sense from you both about what some of the challenges are. But are there enablers? Are there innovations or new ideas that you are seeing where things are actually improving?
Yes. One of the things that we should also be happy about and commend ourselves by our countries, our individual countries, at least for me in Ghana, is the recognition that a lot more needs to be done, particularly by a cadre of citizen activists, persons with lived experience of mental health conditions, who are coming out and standing up. Civil society agencies like my organization, BasicNeeds-Ghana, and several others, including mental health professionals, psychiatrists, clinical psychologists, social workers, occupational therapists, few as they are, all rallying around and pointing out to government to do more. And I think gradually there is a shift. One is the recognition to have a strategic plan, and in it is a recognition that young people's mental health should be given priority, women's mental health should be given priority, which is a step forward. Within my organization, BasicNeeds-Ghana, that I work for, we have had a whole project on school-based mental health, which is promoting school-based mental health clubs, where they are learning more, getting more literacy, knowledge about mental health, common mental disorders, human rights, the Convention on the Rights of Persons with Disability, and all that, so that they could be peer educators, not just for their schoolmates, but also their families and colleagues in the communities who may not be school-based. Again, Basic Needs is part of a research project, the Africa Youth in Mind, which is trying to implement an intervention around young people's mental health. We are talking about the friendship bench, more or less replacing grandmothers with really well-trained and knowledgeable young people reaching out to their peers. And these have been endorsed by the government of Ghana through the Ministry of Health, the Ghana Health Service, and the Mental Health Authority of Ghana.
Well, Peter, that's almost a perfect intro into our final guest, who is equally passionate about the value of peer support for young people. Refilwe works for Anova Health Institute, running their youth care clubs, a one-stop shop for young people living with HIV. Youth Care Club members are provided with support to open up and get help for any mental health issues that might be identified during the mental health assessment. And they can be further referred to care from psychologists or from social workers. Refilwe and the team have worked hard to make the care clubs youth-friendly, giving them a safe space to come back to connect with peers in the same situation, as well as trusted health workers who are relatable and non-judgmental. Eliminating long wait times or awkward interactions with judgmental health workers, the youth clubs have been designed to support both physical and mental health. When we started to record with Refilwe, she was so passionate about her work that she even forgot to tell us her name.
Oh yes, my name is Refilwe. My name is Refilwe. I am a technical advisor, psychosocial, overseeing adolescent and youth program. So Youth Care Club, previously they used to call them support group. We adopted the name because sometimes when this is a support group of alcoholics, it's a support group of, there is a stigma attached to it. So it's a group-based HIV clinical and psychosocial management adolescent and youth program to improve adolescents who are living with HIV. So with this, we just took everything. It's a one-stop shop. We took everything that has to do with screening, that has to do with them, interacting in a one consultation room where we are doing all of this. Now there is a whole integrated screening where now we are screening them in terms of their mental health. How are you feeling today? Based on this, is it from 1 to 10 range? Showing those faces. Are you feeling sad? Are you feeling happy? And that's where now it helps whoever who's doing a screening between the youth ambassador and the professional nurse. And that's where now they're going to, talk about how has their day been? How are they at home? And then now they are sharing the topic of the day. We're talking about stigma. What do you think? What is stigma? They learn such different topics. After they have shared the topic, now they will be going to our professional nurse who's going to hand them their medication. And then those who are unwell, that's where now the professional nurse will be seeing them one-on-one. She will be identifying, what are the issues? Why is this person not doing well in terms of the treatment? Are there issues at home? Or any other issue that the youth ambassador has identified during the screening, then we can just note to the professional nurse that this is one of the things that I've identified during the screening, that he's going through some issues of mental health. She's screen positive in terms of the STI or TB, then that's where now she's able to provide that deeper kind of a clinical management care. Afterwards, just going to do their fun activities, very fun and engaging. Then they are able to go home where they're given now the next appointment dates. So we also do follow-ups with them, having the WhatsApp group with them. While we're at home, there are certain things that maybe we could not as well talk about in the group. We want to talk to the facilitator. There's that kind of chat after hours to say that I'm feeling this way. That's a whole lot of about the Youth Care Clubs.
And for anyone skeptical about the impact of integrating mental health services into wider health care, we then asked Refilwe if she felt mental health impacted on how young people dealt with their HIV diagnosis. Refilwe said that while some newly diagnosed young people adapted well, it could vary.
You'll find that others, they're really not doing well with their medication, and it's all because they're unable to accept it. There's a whole range of emotions around it. There's a whole range of issues around it. The space where they are staying. There are some issues at home, parents, there's a gender-based violence where they are staying. So that kind of whole lot of issues that they are experiencing, hence we ended up have to ensure that this is integrated on a daily basis. When you are providing the clinical care, you are also looking at their mental health.
So Refilwe sees firsthand the benefits of integrating mental health into clinical services. But does she think this is something important to do more of?
Very, very, very much important. Very much important, because even themselves, sometimes they might not know. But having to do that deeper screening of mental health, how are you feeling? It helps them even to, they start becoming aware that, I'm having an issue, I'm having a problem. Because, South Africa is one of the African countries, and, traditionally, sometimes mental health is regarded as something else, So in that regard, you never really take much of a focus or attention into your well-being in terms of your mental health, because it's stigmatized as well. So, you need to cope, you need to be strong, if you are a young boy, and yeah, you just have to strive through all those circumstances. So it becomes normal. But immediately you have been given an attention, you have been asked questions, how are you feeling today? Between this rate and this rate, we're asking more questions. So in that regard, that individual or a young person end up leaving the facility, seeing that, I'm really having a challenge, I'm really having a problem in terms of this area, and being supported, being referred to our psychologist, where they are able to attend to that specific mental health issues.
Thanks so much, Refilwe, for sharing the work that you're doing with Anova Youth Care Clubs. Peter, you've already spoken a little about the importance of doing things differently for young people. Raj, we'd love to hear your thoughts.
I think it is extremely critical to do things differently for young people. And, just mentioning the statistics, like I said, in India, Indian youth are dying by suicide. Youth all over many LMIC contexts are really in need for more care and support. And so I think it's very important, especially in an LMIC context, to look at mental health care, personal agency, how to help youth to navigate safety across different contexts, how to build relationships and community, and access collective action and healing. That's very important for youth, because currently the number of gaps of the systemic failures we have in our mental health system, we are actually failing youth. And so I'll give you an example. And, youth power, I think, can be really transformative when it comes to mental health. During COVID, we put together with a few youth organizations something called the Youth Care Network, and I think Peter was also referring to that. And we trained 35 youth leaders to provide phone-based counseling support, information on services or rights, and also tools for advocacy. Now, these youth leaders provided support to over 400 callers in 16 weeks in English and 13 Indian languages. And they discussed a wide range of issues. And this was absolutely indispensable during lockdown. And this is an example of things being done differently, about the power of youth. So I think it is absolutely critical to look at how to do better by youth.
Wonderful. And so, Peter and Raja, we've come to the end of our discussion today, but I have one last question for you. This podcast is all about doing things differently. So I'm going to ask you the $1 million question. What one thing would you both like to see done differently for mental health in your region? While you think, we'll hear what Mary from the Friendship Bench would most like to see.
One thing that we need to do differently, and when it comes to mental health, is maybe try to address issues around stigma, because you realize we need to reach a point whereby mental health is just treated like physical health, right? Having mentioned a friendship bench within a walking distance, this is so that people can access the mental health service. Just like what we do to pharmacies, you feel a sore throat, you just go to the pharmacy and buy medication. This has to be the same when it comes to mental health issues. So there is need for us to do more sensitization or maybe awareness, to raise more awareness when it comes to mental health issues, so that people have an appreciation that this is something normal. It's just like any other condition, and we can work towards it. Then not just limit mental health issues to having one getting to reach degree level. This is something that one needs to be educated on at an early stage. At kindergarten, one really needs to know about mental health issues, just like how people learn about the physical health. So this is something that we really need to do differently.
Things that both of you had also mentioned. What one thing would you both like to see done differently for mental health in your region?
Yes, thanks. For risk of not being seen not to answer your question, but let me just say, doing more of what we've just done, and I would want to see youth-led voice in this endeavor, seeing more inclusion rather than parallel structures should be the way to go. This is what I can say that we can do radically different, even though if it's somewhat being done at some level.
Raj, one thing that you would like to see done differently for mental health in your region?
So I think in terms of my wish list, I would want to see a presence of mental health understanding and care and support at every primary healthcare center in the country, coupled with a certain amount of basic cash transfer to be given to those suffering distress. But I'm going to add and end by saying this. I completely agree with Peter. I always end with nothing about us without us. And I think the second one should be none of us are free until all of us are free.
Well said. Listen, thank you both so much for joining us today for what for me has been a really enriching conversation. And I hope you enjoyed it as well.
Thank you, Shaffiq and Peter. Absolutely lovely to be here talking to both of you.
Thank you, Shaffiq, and thank you to my wonderful colleague, Raj. Nice to meet you all. All the best.
Thanks so much to Raj and Peter for joining us today. And of course to Mary, Noor and Refilwe. And if you'd like to know more about any of the great work discussed today, please head to the episode notes or our blog over at childrenandaids.org/HIV Reimagined. In our next episodes, we have some great conversations for change lined up for you. We'll be looking at how diagnostics have evolved, especially during COVID, the impact of multi-month dispensing of drugs. So make sure you don't miss an episode by subscribing to Health and HIV Reimagined wherever you get your podcasts from. In the meantime, check out childrenandaids.org/HIV Reimagined for more information and links about this episode of HIV Reimagined. And be sure to subscribe to know when new episodes go live and to join our email list at childrenandaids.org/HIV Reimagined. Please do leave us reviews and ratings, and we'd love to hear from you on what episodes you might want to hear about in the future. Thank you for listening to our very first episode of HIV Reimagined. This is goodbye from Dr. Shaffiq Essajee, and we look forward to speaking with you next time.